Go ahead. Good morning, everyone. My name is Sam Narani. I'm a local gastroenterologist here in Reno, Nevada. I'm one of the few interventional gastroenterologists that practice in this location as well. And I was asked to give a brief lecture on some of the aspects of the interventional things that we can do. I chose just one of the things that I do so we can get a better understanding of it rather than going over the whole smorgasbord. That way we can really apply it to our patients better. So if this is received well and we want to do other things, we can be happy to do that. So what we're going to be doing today is reviewing endoscopic ultrasound. We'll go over exactly what that is, how you can utilize that for diagnostic purposes as well as therapeutic purposes. And again, my name is Sam Narani. I'm an interventional gastroenterologist here in Reno, Nevada. My practice is Digestive Health Associates. So the utility of endoscopic ultrasound has a lot to do with cancer evaluation as well as treatment. We use this to stage malignancies as well as utilizing it as a treatment modality. And we'll go over the technological perspectives behind endoscopic ultrasound as well as how we use it. We'll see how final aspiration can be coupled with endoscopic ultrasound to sample lesions within the body without having to invade the body surgically. We'll see how it helps with the needs of the patient. We'll go over the risks of the procedure and maybe go over some case examples. So the gold standard in staging GI and pancreatic malignancy is endoscopic ultrasound. I just want to say that up front. A lot of people think that it's CT scan or MRI or ultrasound itself or PET scan. It's not. There's been multiple studies over the course of the past 10 to 15 years that have shown that the sensitivity and specificity of utilizing endoscopic ultrasound to stage esophageal, gastric, pancreatic, biliary, and rectal cancer dominates over CT scan and MRI, which is where most people think. Of course, everyone would say, well, CT scan can localize metastatic lesions, and you're correct. If you identify a metastatic lesion and it's automatically a stage 4, there's no utility in endoscopic ultrasound because you have your stage. Why is staging so important? It's ultimately because we utilize stage to determine what treatment we're going to provide that patient. So determining the stage is super critical for ensuring and increasing the chance for cure and remission. So the treatment modalities that can come from proper staging include endoscopic resection. And what that means is now there are certain gastroenterologists that can pass a scope either orally or anally identify the malignancy, and if properly staged, can resect the lesion endoscopically without need to actually cut open the patient. You're going to see more and more of this. Surgical resection would be those that are stage 1s, and then anything higher than a stage 2 typically will go for neoadjuvant therapy. Neoadjuvant therapy is a combination of chemotherapy and radiation therapy to then shrink the lesion, then subsequent restaging, and then hopefully they've had a therapeutic response and will have some type of surgical resection. A lot of people will stop treatment modality there. I would like to enhance treatment modality and include palliation and hospice. I think that's super critical. I know that goes beyond these sort of advanced procedures, but there's a role in palliation and there's a role in hospice, and we should discuss those aspects with our patients as well. We'll be focusing the brunt of this discussion on endoscopic ultrasound and how we stage cancers. But again, ultimately the stage of the cancer ultimately dictates the best treatment modality. So like I stated earlier, there's numerous studies that have shown that endoscopic ultrasound is the best diagnostic method to accurately stage, with the exception of stage 4s, which is dominated by CT and MRI. So if you identify someone who has metastatic lesions to the liver or the lung, and then it looks like they also have a mass, or primary mass in the colon or the rectum or the pancreas. If it's easier to sample the lesion from the lung or the liver to make a diagnosis, that's what is necessary. I would not refer those patients to me for an endoscopic ultrasound of the primary tumor. But of course, happy to hear from you to discuss it further. So endoscopic ultrasound evaluates in stages multiple cancers, like we mentioned: the esophagus, the stomach, the pancreas, the biliary tract, the rectum. Those are the areas that we utilize this primarily from the GI malignancy perspective. And then endoscopic ultrasound is also the gold standard in combination with endoscopic bronchial ultrasound, the coordinated utilization of both EUS and EBUS, endoscopic bronchial ultrasound, is utilized for proper staging of lung cancers. So tumor staging in the GI tract is determined based on penetration of the lesion. So a lot of times we were taught that it's the size of the mass that's important. That's only the case in pancreatic malignancies, in the esophagus, in the rectum, in the stomach. It's not the size. It's how much of that lesion has invaded through the different wall layers, and we'll go over that in future slides. I'll go over that specifically. So assessing the depth of penetration of the tumor is what endoscopic ultrasound is best designed for. We can identify lymph nodes, we can sample those lymph nodes, and we can identify if they've been spread to distant organs as well. So what is endoscopic ultrasound? It's a combination of two techniques. We know what endoscopy is. It's a flexible scope that we can pass orally or anally. And what is then is combined is we take a classic ultrasound technology and place that at the tip of the scope, and then now we're able to do ultrasound inside the body. And so you can actually bring the ultrasound probe in close conjunction to the actual malignancy, and then really appreciate all its characteristics much better than other imaging modalities. So it's the marriage of these two techniques, the imaging of the body's inner wall layers combined with the maneuverability of the endoscope. And it accurately stages GI tumors by 95%. So it enables the endoscopist to use sound waves to generate an image of the transmural anatomy on a monitor, and allows placement of high-frequency transducers close to the intestinal wall and adjacent structures. The procedure generates images. Individual layers of the wall, the digestive tract, are well visualized. You can see blood vessels, lymph nodes. You can see the pancreas from head, body to tail, including the Uncinate process. You can see the left hepatic lobe of the liver. You can see the gallbladder or the bile ducts very easily. It's relatively non-invasive. It manipulates sound waves to view the inside of the body, and unlike an X-ray, there's no radiation. So we utilize the TNM classification for staging of cancer. It's formulated by the American Joint Committee on Cancer. There's a T, there's a tumor, how much of that malignancy has invaded through the wall. The N, are there nodal metastases, and then the M is their distant metastases. The staging ranges from 0 to 4, stage 0 being a precancerous condition, stage 4 being metastatic disease, and then endoscopic ultrasound is used to determine the stage between 1 to 3 by determining the degree of the T and the presence of the N, or the number of nodes identified. When students come to participate in the GI rotation, commonly when they look at the screen, they see ultrasound like this. This is also a form of ultrasound. This is Doppler to track weather, but there's a marked contrast between what is perceived and what's real. What you see on the right side of the screen is an early esophageal cancer, and you can see all the different wall layers very, very well. How do I use this again? So you can see the tumor itself. I'm circling the tumor, and then you can see all the different wall layers. That black layer underneath that you can see is very, very thin. underneath the mass. That's the musculus propria. And then with endoscopic ultrasound, you can see very easily the mass has invaded through the mucosa and then into and through the submucosa, but has not gone through the musculus propria. So this is a very early stage lesion, and this is the person that would be deemed well to go straight to surgery, would not need to have chemotherapy or radiation therapy. So we can evaluate the gut wall on the left on the endoscopic ultrasound image, and then on the right you can see, well, you have to take my word for it, I guess. This is the liver, and then what you see here, this white line is actually a needle that we can pass under ultrasound guidance into lesions, sample them in real time, place them on slides in real time, and then send them to the pathologist, and then within 10-15 minutes, they tell us exactly what the malignancy is. So a patient can have any type of cancer, GI cancer, literally walk into the hospital, and then within 1 hour, we're able to do a procedure that tells them what stage it is, and then exactly what is the histopathology of that malignancy. And then 15 minutes later, I'm on the phone, I call the oncologist, the radiation oncologist, and the surgeon, and then get them appointments, and immediately they go, for their appropriate therapies. And then they wake up and they go home with their families. I've done thousands of these. I've never had any complications, and that's a marked change from how things used to be. If you had a malignancy, in order to be staged, it was typically staged surgically, and it was a big mess. The morbidity was quite high, and there was some mortality with increased mortality with just staging itself. Patients were hospitalized for many days, and then it would impede their flow for proper therapy. So this really circumvents a lot of that. So what we have here, this is the probe itself, the red dot. So the esophagus, we've got the stomach, the diaphragm, and you can see that with this type of endoscopic ultrasound probe, you can pass a needle outside the normal visualized areas of the luminal aspects of the endoscopic evaluation to sample different lesions. So highly valuable. So on this, where the red dot is here, this is the scope, the black. We're looking in retroflex views, which means that we are coming through the esophagus. We're now in the lumen of the stomach, looking back on the scope itself. And you see this mass here, right? And the initial gastroenterologist that did this procedure was very concerned. This was a occult malignancy, referred him the next day. We did the procedure, and instead of being a malignancy, it was just an abscess. So I was able to sample it. It showed findings consistent with an infection. The patient got drained, got antibiotics, and cured. So coupling endoscopic ultrasound and final aspiration, you can use this to biopsy and stage cancerous lesions. Like I said in the past, it would require invasive methods, typically surgical interventions. It permits passage of a fine needle down the scope, so at no time is the needle having to go through the patient's body. And then under ultrasound guidance, you can pass it into the mass, you can pass it to suspicious lymph nodes, and then aspirate that tissue. And that biopsy is known as a fine needle aspiration. So this is the scope itself. This is the channel where the needle comes out, and you basically stab, essentially. You're stabbing the needle into the actual mass. There's a tissue tray and a cutting sheath that allows a piece of the mass or the node to be sampled within the actual needle itself. And then you pull this whole device back into the scope, and then pull it out the scope, and then place a sample onto a slide, and the pathologist can utilize that for analysis to give us the histopathology of the malignancy. So again, this is the same picture that we had before. Here's the needle going into the mass, sampling it. So the combination of this allows us to see beyond the structures that are historically limited our view. These procedures are performed on an outpatient basis. There's reduced pain and recovery time for the patient. It's less invasive, and there's a considerable cost savings, obviously, for the institution. Endoscopic ultrasound has been utilized for over 30 years. It stages esophageal, gastric, pancreatic, bile duct, ampullary, rectal, and lung cancers, helps differentiate benign from malignant gastric wall tumors, and evaluates inflammatory pancreatic diseases and cysts, gallbladder stones, and liver tumors. So we had briefly touched on the wall layers. So here is the lumen. So if we were thinking that we were doing an endoscopy, this is us inside the esophagus, let's say, or inside the stomach itself, or inside the rectum. The first wall layer is the mucosa. The second, the submucosa, musculus propria, and the serosa. And then you can see all the respective wall layers on endoscopic ultrasound. So you don't need years of training like I did to see the differentiation of the wall layers. So when a mass is invading into the wall, you can see how it could be obliterated and giving us the T staging here. So here's a couple of examples of T1, T2, and T3, and then a T4 lesion. And remember, when I say T1, T2, T3, T4, that's not stage 1. That's just the T portion of the TNM classification that ultimately gives us the final stage. And you can see how for a T1, it's invading the submucosa, T2 invading the muscularis propria, T3 invading the adventitia or the serosa, and then T4, it's outside the wall of the esophagus, stomach, and rectum, and it's now invading adjacent structures. So for the example of the esophagus, a T4 lesion would be something invading into the aorta. A T4 lesion in the rectum would be something invading the vagina or the prostate or the seminal glands. So for esophageal cancer, T is the depth of tumor invasion, M is the regional nodes, M is distant metastases, including the celiac axis. So the echo endoscope has those 3 different types. I touched on 2 of them. One is the radial scope that allows for the 360-degree visualization of a mass. That's best utilized for esophageal, gastric, and rectal type of tumors. And the linear scope, some people utilize at this stage. I personally prefer that just for the therapeutic perspectives. The linear scope is the one that allows you to pass the needle into the mass or the nodes to obtain samples. There's also smaller probes. We use these less often. Typically, if someone has a very advanced esophageal cancer or rectal cancer, and we're not able to get the large caliber scope in the middle of it to see how much of the mass was invaded through the wall, we can pass very small caliber scopes or probes through the lumen of the obstructed mass to visualize that.
I understand because it's there and it's convenient.
So the US imaging methods, here's the linear array scope that we talked about, and then the radial scanning. So you have a 360-degree evaluation with the radial, 180-degree evaluation with the linear, and ultimately the reason it's 180 is because you have to use part of the scope itself for the mechanics of the needle. So from the patient perspective, when I explain this to patients, endoscopic ultrasound is like upper endoscopy. However, it typically takes longer because we need to study it longer. The preparation is the same. NPU after midnight, continue medications for hypertension, cardiac disease, pain, or seizures in the morning with a sip of water. With the exception of rectal lesions, they will have to have a bowel prep. The sedation is typically provided by an anesthesiologist, and there's a whole host of different methods they may use to sedate the patient, from simple IV sedation to deep sedation with propofol or complete general anesthesia, depending on the location of the mass. and then we ask that a family member drive them home. Typically, before the procedure is performed, we want to make sure that the risk for bleeding is minimized. So we check a CBC, check a platelet count, like to check a PT and INR to ensure that they have adequate coagulation. And then blood thinners must be held for 5 days prior to final aspiration. And this is especially important for the final aspiration, as we're obviously placing needle through the wall. And although we can see blood vessels, it's important to minimize risk for the patient at all costs. So EUS is a relatively safe procedure and well tolerated by most patients. The primary risks, reaction to the sedating medication like any procedure, which could cause reactions ranging from nausea and vomiting to rash and hives. The IV may infiltrate and cause local swelling. But for most patients having EUS without an FNA, the complications occur 1 in 2,000, less than 0.05%. I've done over 2,000. I haven't had a complication yet. Most significant complication is perforation of the esophagus or the stomach. And again, that has a lot to do with not paying attention to where your scope is going and then pushing too hard. So just got to keep your eye on the ball. Complications are rare. They occur more often in the final aspiration. And again, that has a lot to do with technique. You can utilize Doppler within the ultrasound to visualize blood vessels. So that's one thing that we should always be doing, and that you decrease the risk for bleeding dramatically if you utilize Doppler to make sure that the trajectory of your needle isn't going through any blood vessels. So just one extra step. Infection is a possibility. Even if you don't give antibiotics, the risk is exceedingly low, but one single dose of antibiotics prior to aspiration of a cystic lesion will eliminate or remarkably reduce the risk for introducing infection. And then pancreatitis, obviously you don't want to stab the pancreas, but if you're careful with your needle and you're only sampling the mass and not the pancreas, that itself is also typically quite rare to cause. So EUS has become the most accurate means of staging GI malignancies, retroperitoneal and mediastinal malignancies in the recent years. And it's primarily used as a passive imaging device in the past, but now it's a very involved interventional technique. I've taken it to a degree where, let's say someone goes to the hospital with pancreatitis, it's severe, they develop necrotic pancreatitis, where a portion of the pancreas essentially dies, it becomes necrotic. They stabilize, they do well, and now they have this basically phlegmon of necrotic mass. Previously, you would send them to the surgeon would cut them open, debride the mass, significant infection risk, highly morbid. Now what we do is endoscopically, with endoscopic ultrasound, I'm able to visualize the necrotic portion of the pancreas. And under ultrasound guidance, we would basically perforate the wall of the stomach, place a large stent through the wall of the stomach, communicating the lumen of the stomach with the necrotic mass. And then I take out the EUS scope and then place a normal endoscope through the stent and through the necrotic mass, and then debride all of that necrotic dead tissue into the stomach, inject different solutions, antibiotics, hydrogen peroxide, and basically sterilize the inside of the necrotic mass after I've debrided all the dead tissue, and then pull out the stent, and then you're done. And that typically takes about an hour, hour and a half, and they walk into the hospital and they walk out of the hospital. I've done that probably 20, 30 times now, and the patients do exceedingly well. We also use endoscopic ultrasound to place fiducials. So the radiation oncologists will now ask us to place gold fiducials for better imaging and then application of radiation. So we'll place fiducials for them. Some of the more advanced individuals will also treat pancreatic cystic lesions in a non-surgical manner by identifying the cystic lesion. And this is, you have to choose your patients very carefully, of course. These are patients that would not do well with surgery, would not do well classically with chemotherapy, and you're trying to buy them some time. This is typically in a research setting. You'd identify the cyst, you would aspirate the cyst, and then you inject paclitaxel, which is a chemotherapy agent we use for pancreatic cancer, and or ethanol to ablate that lesion. And some of the earlier studies are showing some promising results. So there's a lot of different things you can do. If you're having difficulty accessing the bile duct, you can utilize endoscopic ultrasound to actually pass a wire through the bile duct and then grasp it as it comes out the ampulla. So there's a lot of different tricks, just depends on your skill level. So it's really utilized for final aspiration and for the diagnosis and staging of pancreatic cancer, nodal staging of GI and pulmonary malignancies, and therapeutic EUS is based primarily upon precise and endoscopic needle placement under EUS guidance. Other therapeutic uses can be used for pseudocyst drainage, like I mentioned. We can inject botulism toxin for the treatment of achalasia, and then those patients who have advanced disease and have severe abdominal pain secondary to advancement of the pancreatic cancer or esophageal cancer, we can do a celiac nerve block or identify the celiac axis under ultrasound guidance and then inject different solutions essentially to block the transmission of all the pain receptors. And that helps with end of life palliation, decreases narcotic consumption. Do you have any questions? That's pretty much the end of it. It was a pleasure. Thank you so much.
Go, what's going